Hi everyone, welcome to this UCL Centre for Longitudinal Studies webinar looking at hospital episode statistics linked into the CLS cohorts. My name is Richard Silverwood. I'm an Associate Professor of Statistics based at CLS. We're just going to start off with a little bit of housekeeping. It'd be great if you could keep your cameras off and your mics muted at all times. If you've got any questions, please use the chat function, but do note that your question will be visible to all attendees. And as you'll see when I show the schedule for this webinar, there should be plenty of opportunities for questions at the end of the session. We're very grateful for your feedback, which always contributes to how we plan and develop our training program, and there'll be a short survey linked to at the end of the webinar. So it'd be great if you could contribute to that. I'll try and remind you about that later too. And just to note that these slides and the recording will be made available shortly after the session. So if we get a bit tight on time and have to skip one or two slides, then don't worry, you'll still have access to the material. So what are we going to look at today? So as I say, the focus is really on the HES data that we have linked into the CLS cohorts, but I'll start off by just briefly describing those cohorts themselves so that it's clear what we're talking about in terms of that end of things. Then Sarah's going to give us an overview of the HES data and the linkage itself. And then Danielle and Karen are going to discuss how you would go about accessing the linked HES data sets for yourself. And then I'll have a slot looking at some of the kind of features of the HES data and how you might go about utilizing some of those in analyses that you may wish to conduct yourself, as well as kind of flagging up a few recent analyses we've been conducting ourselves, just to show the sort of thing that can be done. And then, as I said, there should be plenty of time for questions at the end. We'll all be available to address any questions that you might have. So feel free to post the questions during any of the slots, but I think we'll probably save them all to the end and address them at that point. So as I say, just a brief introduction to the CLS cohorts to start off with. So at CLS, we run 4 cohort studies, the 4 listed here. So the National Child Development Study is a study of all babies born in 1 week in 1958 in Great Britain, so England, Wales and Scotland. The 1970 British cohort study is similarly covers the Great Britain and its babies born in 1 week in 1970. Next Steps is a little bit different in its recruitment, in that it was individuals born in 1989 and 90, but they weren't recruited until they were age 13 or 14 in school. So we don't follow that first part of their life, just from age 13, 14 onwards. And the Millennium Cohort Study is a sample of babies born between 2000 and 2002 across all of the UK, so additionally including Northern Ireland. And these studies are all a fairly similar size, sort of between 16,000 and 19,000 at recruitment. So I think this plot's a nice way to visualize how we've collected data across these studies. So we've got age on the x-axis and year on the y-axis, and the dots for each study represent the points in time and their ages at which we've collected data. So we can see that for all of the cohorts, with the exception of Next Steps, we've collected data at quite regular intervals across the life course so far, generally around every 5 years or so. And we can see that in Next Steps, because as I said, they weren't recruited until they were age 13 or 14, there's no data collections prior to that point, but then they were observed every year after that for the next, I think, 7 years, and then once again at age 25. So all of the studies at the moment, because of some delays to data collection due to the COVID-19 pandemic, they're all at the moment out in the field collecting data. So I think that's kind of age 62 in NCDS, age 51 in BCS 70, age 32 in Next Steps, and in MCS it's kind of age 2021. So those data will be available over the next year or so, but at the moment you can see there where the most recent data are available. So these are really, truly kind of multidisciplinary studies we're collecting data across a really wide range of features relating to these individuals and their lives. The type of data that we collect is pretty consistent across those different studies, but it naturally differs depending on the kind of life stage that the cohort members are at. So as you can see here, just some examples of the data that we're collecting at those different life stages. So at birth, we'll be collecting information on household composition, parental social class, etc. You can see, I don't need to read them out. As the children, the cohort members come into school age, then you can see that we're collecting some information consistently across these different life stages, but also new features about the cohort members themselves. So particularly then thinking a bit more about how they're performing at school, their cognitive ability, their emotions and behaviours and their views and expectations. And as we go into adulthood, that transition from childhood into adulthood, we start thinking more about what they do in terms of continuing their education, in terms of going into employment, partnership formation, marriage, and then lots of interest in the kind of socio and economic features of their lives well into adulthood. So as I say, there's lots of these things that we're observing many times across the life course, which gives us the potential to look at these things in a longitudinal manner. I haven't really mentioned health there much, and I should do, because really the focus of this webinar is thinking about the HES data, so health data, and there is a large amount of health data that's collected within the cohorts, either self-reported, so about specific diseases and conditions, about general health, but then also there's a lot of information collected on biomarkers, so around height and weight, blood pressure, and at some of the sweeps of data collection, there's specific nurse visits or visits of the cohort members into clinics to collect more detailed information. And increasingly, we've got genetic information as well within the cohort studies. So that was just a very brief overview of the cohorts and what's contained within them. And I guess hopefully, if you're not familiar with them already, then that will allow you to think a little bit about how the linked HES data might add to the information that we have and the sort of analyses that could be undertaken using this cohort data in conjunction with the linked HES data. So before we move on to the next slot, I just wanted to use this opportunity to advertise a few forthcoming training events. So in January, we've got a session on Introduction to NCDS, so the cohort born in 1958. So if you want more information on that, that will be a good opportunity. And we have these introduction to each cohort study across the year on a regular basis. So there'll be similar sessions for the other cohorts later next year. We've also got an introduction to the CLS cohorts for biomedical researchers that's run by Closer in February, and then a session on how to handle missing data in the CLS cohorts in February, which is a very important thing, because obviously with these long-running cohorts in particular, there's to a certain extent attrition over time that certainly needs to be accounted for in analyses. And then finally, I just wanted to also flag up this opportunity. So next summer, there'll be a scientific conference in London celebrating 21 years of the Millennium Cohort Study. And there's currently a call for papers. So if anyone out there is already or thinking about doing some analyses, including MCS data or data from similar kind of millennial longitudinal studies, and would like to submit an abstract for that conference, then there's more information on that on the CLS website. Great, and at this point I will pass across to Sarah. Thank you.
I'm just waiting for my slides to load. Brilliant, can you see those?
Yeah, got that.
Brilliant. Okay, yes. So this is NHS. We're talking about NHS England, right? In the UK, the NHS Health Service is devolved into the 4 nations. I'll be discussing the hospital episode statistics, the HES dataset from NHS Digital in England, and I'll briefly touch on what we've got, the Scottish medical records, but this is primarily about the HES data. Yeah, so we have we've actually got hospital episode statistics linked to each cohort, including MCS, but that's available as of tomorrow. So there's a little plug there. You can start applying for it tomorrow. Yeah. Okay, so the user guide that's on the UKDS, it covers everything you need to know about the data. It's quite comprehensive. This is the contents page, and there's a brief explanation of both the cohort and the data available, and the nature of the consent, like how it was obtained, is described. Also, the linkage to the health data, including the matching strategy rate and rates, and how confidentiality is maintained throughout this process. And then the licensing arrangements behind accessing the data are explained as well. And each supplementary file is listed, and you can look them up on the internet too. And the file details how the supplementary data should be used in conjunction with the HES data. So any additional processing that we've done is also explained broadly in the user guide. It's usually changes to do with disclosure risk, and these are all in the appendices. So I'm just going to clear my throat because it doesn't sound quite right. Okay, sorry about that. Then each data set are introduced individually in the user guide. And then section 6 is all about the information about how to apply for the data given. And Danielle's going to talk about applying later. Okay, so these are the data sets available. I'll go on and talk about each in depth, but as an overview, admitted patient care, this details the hospital admissions, the overnight stays. The critical care dataset is linked to the APC, the admitted patient care dataset. So every critical care episode has an APC episode that is associated with. The accident and emergency dataset discusses visits to A&E. Hang on. And outpatient care would detail the appointments that don't involve admissions. If either accident or emergency, if either accident and emergency or outpatients result in an admission, then this would result in a record in APC. However, they are not directly linked in the way that APC and critical care are. So there's no one identifier that links them together. And then the emergency care data set we've only got for MCS because it's very new, and that that's superseding the accident and emergency care data, the accident and emergency data set, and that I'll go into detail about it later. But yeah, so we've only got that for MCS because it's new. So yeah, so this is, I'm going to talk about next steps, NCDS and BCS 70 here, like what years we've got available. We've got accident and emergency data collected between 2007 and 2017. The admitted patient care is collected between 1997 and 2017. The critical care started collection in 2009, and the outpatient care started collection in 2003. And actually, for next steps, we have up to 2016, not 2017. And then for MCS, they're obviously younger, so they don't start in 1997. And it runs until 2020. And the emergency care starts in 2018, 2017. Let's go on. Right. So this is the this is how we link the data. The cohort maintenance team, they send a list of identifying information for consenting cohort members. This is created alongside an ID for linkage only by the research data management team. So we don't see the identifiers. And then we as the research data management team, we don't see the identifiers, we just give the ID. The information is then used to match to a HES ID, and then they give us a match quality variable which is it summarizes the variables used to create the match for each record. I think it's actually called a match quality indicator. The HES ID is used to then retrieve the hospital data for each individual that's been successfully linked. At NHS Digital, that bespoke ID that we sent, that's retained and the HES ID is removed, so we don't see the HES ID. Then this is sent to the RDM, the Research Data Management team at CLS, us, who that we link it to the cohort data and we process it for sharing. So consent for linkage was sought at different sweeps for the different cohorts. For next steps, was age 25, for BCS 70, age 42, NCDS age 50, and MCS age 17. Just under 2/3 of next steps consented, and of those, most were matched with at least one data set. In BCS 70, 70% were consenting, and just over 70%, and 78% of those were matched at least one data set. I'm just going to have a sip because my throat is not clear. It's really bothering me. Right, okay. For NCDS, again, just over 70% consenting and 88% having at least one record in the data set. I'm going to put MCS here, but I haven't summarised it. Yeah, so there's more in the MCS data set. There's 10,800 roughly consenting, and like 87% gave consent. Sorry, 87% of 10,000 gave consent, and 81% had matched data, so it's quite good. Right. So this shows the number of cohort members in each HES data set for each cohort. So these dotted lines here at the top, they show the number with a matched variable. You can see that a high proportion have at least one outpatient appointment here. For NCS and BCS, fewer still have A&E, but the next steps records have slightly higher in A&E, and actually MCS have even more. Critical care records, they're rare in any records. Bear in mind this doesn't cover COVID-19 yet. So here's the structure of their data. It's organised into episodes, so continuous period of patient care administered under one consultant within healthcare providers. So you could have multiple episodes for one stay or one visit to hospital. Each episode is one row in the data set, and I think Richard's going to talk about this actually later. So and then a hospital spell is the total time spent by a patient in the same care provided by a hospital from the date of admission to the date of discharge. Spells cover one or more episodes, and so if you want to avoid double counting, you use the last episode in the spell because it has a lot of information, although I think again Richard has some more detail on that. So what's available in the admitted patient care? There's diagnostic codes, which are coded in ICD10, operations, and that's procedures as well, so it's not just like what you think theatre operations, but it's also any kind of intervention really. Maternity data, so birth weight, labour, outcomes, resuscitation, they're all recorded. Indices of multiple deprivation are provided as individual scores and as deciles. Administrative patient care, like health authority, GP practice, purchasing code, they're provided, although GP practice is pseudonymised. Some other provider codes are actually pseudonymised. Many dates, including admission, discharge, referral, as well as the reason for the admission and the discharge destination, which is destination being like where they end up. Critical care contains the type of support that was provided to the patient and the number of days that with that assistance. Every critical care episode, like I said earlier, is linked with an admitted patient care episode. And the information from the admitted patient care record will be needed to understand the data in the critical care. You need them both in Link. Right. So note that the diagnostic codes in accident, so we've got outpatient care and accident and emergency. The diagnostic codes in A&E are not the same as the ICD10 codes in the rest of the data sets, apart from the next one. And in outpatient care, a lot of the diagnostic codes are actually coded as like non-specified or unknown. So just bear that in mind. And well, yeah, I'll go on to SNOMED. Right. The emergency care data set, it supersedes the accident and emergency data set, and it uses the SNOMED CT medical vocabulary. The data are really well coded, and it's a vast improvement on the A&E. I think I know that they set this up to kind of answer the problem of the irregularities in the coding in the A&E data set, and it's, from what I've seen, it's really clean, and it matches up to labels really well. So I think it's really promising. It's got diagnostic codes, causes of injury, also place of injury, not geographical place, but home, school, that kind of place. Drug information, lots of information about treatment, and then again the usual dates, arrival, when they're seen, and when they're discharged or admitted. So there was quite a lot of supplementary dictionaries and documentation. They're uploaded into the secure access server, so you can use them for reference. Yeah, and they remain, you know, as you know, you can't be on the internet at the same time as being in the secure access server, but you can look up the references if you're not in it. So if you're just preparing something in advance, you can look at these online, and I've linked them in the user guides. Yeah, so the files are referenced in the user guides. The links should be clickable. The NHS data dictionaries, I've actually moved on from the data dictionaries now. I have to update that. And they provide also, there's a guidance to analysis, so how to analyse the HES data and also what's acceptable as an output. Like the ICD10 codes, they describe not only diagnoses but symptoms and causes. They come from the WHO. And it's worth familiarising yourselves with all the ontologies that are used in advance of researching the HES data. This is just a look at ICD10, it's a hierarchical structure. So the letter at the beginning, it indicates an umbrella chapter under which the diseases in that category occur. So you can see here category A pertains to infectious parasitic diseases. And on the right, you can see subgroups such as tuberculosis. If you click on A15 to A19, types of TB, you can see the definition of A15. We've actually truncated these codes, but I think, as Richard says later, this is actually a lot of detail still, and you might even want to take it back to a higher level to analyse. One way that these codes are used is to draw up a code list which contains diagnoses or symptoms which would indicate a certain trait or outcome you're looking for. And you do this prior to analysis, and it could be included in the application. And just briefly, what's available in the Scottish medical records. Unlike HES, we have different data sets for different cohorts apart from the ECDS. For all the cohorts, that's MCS, BCS, 70 and NCDS, we don't have next steps because they were recruited in England. We've got prescriptions, outpatient and inpatient records. For NCDS, we have BCS 7, for NCDS and BCS 70, we've got maternity records. And for MCS, we have birth and neonatal records, immunisations, child health reviews, because they're so much younger when we've applied for this data. Not sure why there's an H there. Okay, I know that we're not. Oh, that's the end.
Hello, everyone. So I'm Danielle. I'm Records Linkage Manager at CLS, and I will go through the process of applying to this data to access this data. So the data that Sarah has just presented here, this specific data set is only available via the UKDS. However, CLS cohort studies are also linked to other health data and currently available via the UK Longitudinal Linkage Collaboration, the UK LLC. At the moment, via the UK LLC, it's only available for researchers who would like to do research, COVID-related research. And my colleague Karen will later on present about the UK LLC. So I'm going to go now through the process to apply to access this data via the UKDS. Okay, so in order to apply to this data, you must be present in the UK. You must be affiliated with a higher education or a further education institution. You also need to be an accredited researcher. And your user agreements, the documents that you signed with the UKDS and with UCL, must be authorized and signed by someone who can take legal responsibility on behalf of your institution. You also must be able to access the data from a suitable, safe environment that meets the UKDS security requirements. So to access this data, you go online on the UKDS website. If you haven't registered before, you'll be required to register. We have provided a few slides describing the process to register and to download the dataset. However, I'll not go into this in much detail, but feel free to access the slides if you need further help with the application process. So once you have created your account, you arrive at this webpage. So you see a box like this on the UKDS website in your account. The items on the left will show you all the steps that you need to complete in order to access this data. And on the right side, you see here we have BCS 70 has linked data. In your case, will be whichever data set you have chosen to access. By clicking in that link, you will be able to download a zip file, which will contain the full documentation that you need to complete to access this data. So for both the HES and the SMR, the Scottish Medical Data, you go through the same process, you fill in the same forms, except that for the HES dataset, there are two additional documents. There is the CLS license agreement, and there will be also the HES variables list. So for the HES data, you need to specify which variables you would like to use for your project. Okay, so each member of the team, including the project lead, must download and complete both of these forms, so the Secure Access User Agreement and the ESRC Accredited Researcher Application Form. So the Accredited Researcher Application Form requires you to provide evidence of your suitability as an ESRC researcher. So if you already have completed these steps, this will be already marked as complete for you, so you will not have to do it. And once you complete all the forms, you will send it to the UKDS via email, the email address which they will have provided to you. So the Secure User Agreement. So both the user or the researcher accessing the data and the organization responsible for the research need to read and agree and sign this agreement. So this is an agreement that will be between your organization and the University of Essex, which is the organization hosting the UKDS. So Then if you're accessing the HAS data, you also need to do this additional agreement. This is an agreement between your organization and UCL. So in this agreement, if you are an UCL researcher or from CLS, please note there is a variation of this form. You need to complete the one that says UCL users only. So you look out for this one. And if you don't see this in your pack, but it should be there, it should be included, you can ask the UKDS for this. So this form needs to be completed, and there are some NHS digital requirements that we would like to highlight here, which we would like you to pay additional attention to those. So there are some sections in this document, such as the legal basis. So CLS receives this data under the legal basis of public task. And we can only provide the data to organizations which also will be accessing the data using the legal base of public task. So you can only apply, really, if your legal basis to accessing this data is public task. Under the section Organizational Security, you will be required to provide some assurance that your organization has a security assurance. This could be like the ISO 27001, in which case you could upload a copy of the certificate with the application. If you have the NHS Digital Toolkit approval, this is also acceptable. And in this case, you could just put the ORB number on the application. If you don't have any of those, we would accept a system level security policy, and you would also be asked to provide a copy of this. We would just ask you to make sure that is the latest version of the policy, is the updated version. In addition to that, we recommend that you really complete the section on the benefits to health and social care in as much detail as possible. This is one of the NHS digital requirements, and is one of the things that the DAC, who is going to be approving your application, will be also assessing. Then you will see the variables list. For the HAS only, you need to complete the variables that you would like to access for the specific project which you will be applying. So once you have completed all documentation and you have sent it to the UKDS, they will screen your applications. They will, if they are happy with it, they will send it. They will send it to CLS, and it will be reviewed by the Data Access Committee at CLS, the DAC. The DAC will look at your application as a whole, the full application, especially those requirements from NHS Digital. The benefits to health and social care needs to be there. They will look into the variables you have chosen, and whether you have specified why you need those variables, if the research question also somehow matches the variables that you have chosen. Then, if you haven't done the training, the Safe Researcher training, the UKDS will invite you to do the training. All team members must complete the Safe Researcher training course, and you can find more guidance on this in your account, in the UKDS account. They will provide you with guidance. Also, you can contact the desktop at UKDS. They will guide you through the process. So in addition to all the documentation that you need to complete, each member of the team who is accessing the data for this project or for your project must complete an online secure lab account setup. So the access to the UKDS secure lab is via this remote desktop access with access to a standard software packages. So your outputs will also be checked for disclosure control before being released from the secure environment. So here we have some links for more information on how to apply. You can refer to the links. We also would like to inform about the data. We have the Welsh data that we have available. We have these data sets: the emergency department data set, primary care, outpatient data set, patient episode database, and these are all available via the SAIL data bank. And there are two stages for application of this. There is a first stage, which is a scoping document to be completed by a SAIL databank analyst, following a discussion with you about the project. And then the stage 2 is the application to gain the Information Governance Review Panel, the IGRP approval. So in the near future, we are currently applying to refresh the HES data we currently have available. So the current data sets for NCDS and BCS 70 and next steps available now, which Sarah was just presenting, they cover data up to 2017. For next steps, we have the data now from 2017 to 2022. We're just preparing this data and hopefully it will be available within the next 3 months. For BCS and NCDS, we're in the process of approval with the NHS Digital, so we hope that next year this data will be refreshed. And also CLS will refresh the Welsh health data set, which is linked to MCS, currently available at the SAIL and the UKDS. And that's all from me. I will pass it on to Karen now.
Hi, I'm Karen Dennison and I'm a Records Linkage Manager for CLS. As Danielle mentioned, in addition to depositing data with the UK Data Service, we also make our data available via the UK Longitudinal Linkage collaboration, which is a new resource for the longitudinal research community. So I'll just take a few minutes to present some slides which have been provided to us by the UK LLC. It's funded by the UKRI, UK Research and Innovation, in collaboration with a number of institutions. And it's part of a programme which aims to understand the long-term impacts of COVID-19 on mental, physical and economic health. So therefore, it's currently available for research into COVID-19 only, but there are plans to provide access for wider research purposes in the coming months, subject to funding. So it's an extremely data-rich resource, and it contains data from a large number of longitudinal population studies, including the 4 that CLS run. Survey responses and baseline indicators are made available, linked to individual level, to a range of NHS data, including COVID-19 datasets and wider NHS datasets, including the HES data. And the linkages are available for consenting cohort members. There's also approvals in place to link in additional administrative records, so economic records from HMRC and DWP, and education records and school census data from the Department for Education. So it uses a trusted research environment with secure remote desktop access to the data. And there's a novel NHS digital data pipeline in place, where the NHS data are updated every 6 months or annually, depending on which data. And there are over 20 participating longitudinal studies, which are shown here on this slide. I won't read them out, but you can go back and have a look. So to kick off the application process, you submit an expression of interest, and this is done via the Health Data Research UK Gateway. And there's a link there, and you search for the UK LLC, and there's a link on how to access, and you proceed from there. You'll then be directed to a fuller application and asked to provide details of the researchers, a project overview, a lay summary, the required data, a justification for the data, and how the project will benefit health and or social care. So similar to what Danielle was describing for the UKDS. The application is then reviewed by a panel which has some public representation on it. Once approved, data access agreements need to be agreed to and signed, with one being needing your institutional signature. And before being given access, you need to be an ONS accredited researcher, which involves completion of a safe researcher training course, which is the same course that Danielle mentioned previously for the UKDS. Access to the data is via remote desktop environment. You get project-specific database views to access the data that you've requested, with access to code lists and code mappings and standard software packages for data analysis. And as for the Secure Lab, the outputs are checked for, as for the UKDS Secure Lab, outputs are checked for statistical disclosure control before being released from the trusted research environment. And overall, the access to the data is like a very similar method to the UKDS Secure Lab using a trusted research environment. So looking ahead, there's lots of other things going on, but this is like the most relevant bits for this very brief overview. The UK LLC is currently funded until May, and there's an application for new 5-year funding submitted. And then looking forward over the coming months, planning to open up to research beyond COVID-19, the addition of NHS data from Wales and Scotland. It's currently data for England, and also the addition of the HMRC, DWP and DFE data. And there's an email address there should you have any questions to direct at the LLC. Thank you.
Great. Hopefully you can see those now. Okay, so I just wanted to spend some time now, I think I've still got about half an hour, to really look at some of the key features of the HES data and think about the types of analyses that you might want to do. So I'll spend the majority of this slot really thinking about the HES data structure, some simple data checks that you might want to do, and then some of the key variables, particularly those that cut across several of the HES data sets. So in particular, the ICD10 diagnostic coding and the OPCS intervention and procedural coding. I'll quickly think a little bit about defining your analysis sample, because I think that might differ depending on exactly what you're intending to do. And then if I've got time, just look briefly at a couple of recent analyses that we've done, one very applied, one more methodological, just as examples of what can be done using this linked data resource. And then finally, flag up some of the resources, I think many of which have been described already, but just to reiterate some of that. So first of all, thinking a bit about the data structure and some of the key variables. So this slide is very much repetition of what Sarah was saying before, but I think worth just reiterating at this point. So each record in HES, each row in the data set is an episode. The episodes relate to a period of care for a given patient, under a single consultant within one hospital provider. So if a patient moves to a new consultant, or if they move between hospital providers, then a new episode will start. And the stay in hospital from admission when they arrive to discharge when the patient leaves is called a spell, and that can be made up of one or potentially several episodes of care. So we can think of the data set as being of a hierarchical structure. Essentially, we've got patients at one level, nested within those there's potentially different spells of care, and then nested within the spells of care there'll be these individual episodes making up each row of the data set. So here's an example of what some HES data might look like. So these data are completely made up. I wouldn't be sharing any real HES data in this forum. And here it's just focusing on the key variables. And I think really these are, some of these will be common to all of the data sets, but I guess I'm basing this more on the admitted patient care data set as a focus. So what do we have here? So this is our NCDS ID number or serial number, which allows us to distinguish between different NCDS cohort members. This variable is a pseudonymized hospital provider spell number, so it allows us to distinguish between different spells or identify which episodes are within the same spell. We have the date of admission when the patient arrived at the hospital. The episode order, so this should be number 1 for the first episode in a spell, and then go up sequentially from there if all's gone to plan in the coding and the data access. The date the episode started, the date the episode ended, and then the discharge date is the date the patient left the hospital at the end of the spell. So it should be the same as the date of the end of that final episode. And then finally, in this subset of variables, this spell end is just an indicator for whether a given episode is the final episode of a spell. So let's just have a look through these in turn. So I've highlighted the rows relating to a single NCDS cohort member in turn. So this first cohort member only has one row in the data set. So one episode, which itself makes up one spell. So they were admitted on the 16th of January 2010. This single episode started on that date and ended on the 18th of January 2010, which is the date on which they were discharged. And correctly, this is indicated as being the last episode within a spell in that final variable. The second cohort member here has got 2 rows in the data set, so 2 episodes. We can see from this second column that they have the same spell identifier, so we know that they belong to the same spell, the same admission. And we can see in the epi order column that these are labelled as episodes number 1 and 2. So this patient was admitted on the 7th of August. They had their first episode, which also ended on the 7th of August. They transferred into a second episode, which went on for another 4 days until the 13th of August, at which point they were discharged. And we can see from the final column that only the second of these episodes has been correctly identified as the final episode in the spell. And then finally, the third NCDS, the fictional NCDS cohort member here, they have 5 rows in the data set, so 5 episodes that we can see from the in the second column, the code. These are made up of 2 different spells. So the first one goes from the 21st of February 1999 to the 25th of February 1999 across 3 episodes, and the second one is in November 2015. So hopefully that illustrates the basic structure here. Again, there's lots of other variables that are available in the HES data set, so that's just a subset of the more important ones in terms of the structure, and we'll subsequently be looking at some of the other variables that are useful for different purposes. It's definitely useful to think about some basic data checks. I know that the team here have been doing quite a lot of processing on this data, but it's the nature of this type of data. It's administrative data. It's been coded up for kind of administrative purposes, and it has over the years increasingly been used for research purposes, and the quality of it has improved over time. But it's certainly worth performing some basic checks to familiarize yourself with the data, and in particular, just be aware of any potential holes or issues with it more generally. So the variable completeness and the data quality does differ by the variable, it differs by the HES data set, and as I say, it has improved over time. But you might want to think about some basic checks on these basic variables and the structure, just thinking about whether the dates are correctly recorded and formatted. So when a plausible range for when they should be, the range of dates covered by each HES data set, and you can also look to see whether the order of the dates within a spell makes sense. There's not one that's 2 years later, or one that's 2 years, they're discharged 2 years prior to their admission. And then also looking to see whether the observed episodes within a spell are consistent with epi order. As I say, it should start at 1 and go up in integers from that point until discharge. That's not necessarily the case. And I think, you know, with some of these issues that you might identify, it's not always clear exactly what you should do to overcome that issue, whether it's a case of, you know, recoding something to a more sensible value, recoding it to missing, which might lead to its exclusion. And I think that will rather depend on the context of the analysis that you're doing. So I wouldn't propose any hard and fast rules for any of those. So I'm going to look in a bit more detail now at the ICD-10 coding, International Classification of Diseases, version 10, to give it its full name. We've heard a bit about this already. This codifies diseases, signs and symptoms, abnormal findings, complaints, social circumstances, and external causes of injury or diseases. So fairly broad. But I think this coding is used across multiple of their HES data sets, as well as other data resources that you might use. So I think it's worth thinking about this a little bit. So similar screen grab to what Sarah showed earlier. But here I've just searched for hypertension, and you can see that it's told me on this coding, this website that details the coding, that there is within chapter 9, diseases of the circulatory system, there's a section here with the codes between I10 and I15 on hypertensive diseases, and it breaks it down into an even more granular form on the right hand side. So I10 is essential or primary hypertension, I11 hypertensive heart disease, etc. So that's just as an example. And as has been said already, the codes are broken up neatly into chapters, going from chapter 1, certain infectious and parasitic diseases, to chapter 22, codes for special purposes. I say they're broken up neatly, but as you can see, the codes don't always correspond that neatly to the chapters. So chapter 1 includes codes beginning with both A and B, and the codes beginning with D fall into both chapters 2 and 3, depending on the rest of the code. So just something to be aware of. So again, some made up data here. This is the same NCDS cohort members and the same spell identifiers, but the remaining ICD-10 variables are just, you know, new variables that would have been further on in the data set from the snapshot that I showed previously. And here we have these variables relating to the truncated ICD-10 codes, so diagnosis 1, 2, all the way up to 20 in the APC data set. At least the codes are used right the way up until 20. And these I've just completely made up. So if anyone knows anything about these codes, they will quickly spot that it probably doesn't make any sense that some of these appear in combinations. But just to look at a few of them, so I77 is other disorders of arteries and arterioles, Z85, personal history of malignant neoplasm, G35 is MS, Z51 is other medical care. So they're often quite granular. And so you may not use them in their original form. You may have to do something to get them into a more usable format, as we'll consider in a couple of slides' time. So again, just to go through by cohort member, this first cohort member got a single spell made up of a single episode. They've just got one diagnostic code within that. This second cohort member, single spell made up of 2 episodes, they've got 3 diagnostic codes, and they're repeated exactly the same across the 2 episodes that make up this spell, and that is generally the case. That's a common feature of this coding, that it's generally done at the spell level rather than the episode level. And we can see similarly so for the 2 spells for this third NCDS cohort member. So as I say, these ICD-10 codes are quite granular. Over a linked HES data set, you may see hundreds or thousands of different codes. So depending on exactly what you're doing with the data, it may be too granular for what you're looking to do. So you may want to use a code list that you've developed, or maybe if you're not a clinician, maybe developed in collaboration with a clinical colleague, as is often the case, to think about exactly which of these codes you would want to group together to identify the diagnosis or diagnoses that you're interested in. So here I've gone from one extreme of granularity, maybe too far in the other direction, to just group these into their chapters. So if I go, excuse me, and just skip back to the chapters, we can see here chapter 1 was codes, all the codes beginning A and B. Chapter 2 is codes beginning all the C's and then D up to D48. And we can just write a little bit of code that will bundle all of these. So here we're just generating a new variable. So this is Stata code, but hopefully it's easy enough to follow. It's not necessary to follow it. It's just I think some people enjoy seeing a bit of code to see how it would be done in practice. So a new variable that's just the here we're just using the first diagnosis slot, the primary diagnosis, and this new variable is just going to give us the chapter that is indicated by that ICD10 code. So we generate a new variable, replace it with 1 if it's a ICD10 code that relates to chapter 1. So that's 1 where the first value is A or the first character is B, and then replace it with value 2 if it's in chapter 2. So that's if the first character is C, the first 2 characters are D0, etc. So here, as I say, that's just using the first diagnosis code slot, but we could expand it to all of those diagnosis positions by looping over each of those variables. And so that would give us a derived variable at the episode level. So within a given episode, we would be able to see if a diagnosis within a given chapter had been was present, or sorry, if that's just for a single diagnosis with a single diagnosis slot within a single episode. But we probably want to do that looking over spells, or potentially as a kind of ever variable, whether an individual has ever had a certain diagnosis. So we could do something fairly straightforward here, just deriving a new variable for chapter 1 diagnoses. First of all, derive an indicator, so just a variable taking value 1 if the chapter for that diagnostic code is 1 and 0 otherwise. Then generating a new ever variable, and just by ordering it across this new variable within each cohort member, replacing this new variable with the final value of that, which will be a 1 if that a diagnosis code from that chapter has ever been observed, we will get an ever variable for that diagnosis. So as I say, don't need to follow that, but maybe helpful to see how it will be done in practice. And again, you can to looking over all chapters by looping over the chapters. So that OPCS coding, the Office of Population Censuses and Surveys classification of interventions and procedures, is again used, I think, across a couple of these HES data sets, and this codifies the operations, procedures and interventions performed during inpatient stays, day case surgery and some of the outpatient treatments in the HES data sets. So again, this is an example of an online browser that you can use for looking up these codes. This one provided by NHS Digital. And here I've just searched for appendix to see what it gives me back. And we can see here that these codes beginning H are a good source of procedures or interventions to do with the appendix. So emergency excision of the appendix, I guess an appendectomy, and different variants thereof. So again, that's just an example of what some of the codes would look like. And we can see here that the full codes for a specific procedure or operation have 4 characters with a point, a full stop before the final one. But when we see here the way that they're coded in the HES data set, that's omitted. It's just the 4 characters. So again, similarly to the ICD10 coding, these fit quite nicely into chapters. In fact, more neatly so than for the ICD10 coding, because the first character of each of these codes does exactly map onto the chapter. So from A, things to do with the nervous system, through to Z, which are subsidiary classifications. The one exception, as I note at the bottom, is that codes beginning with an O or overflow codes, so they do need to be handled slightly differently. So again, some completely made up data where these codes might not make sense in combination. So here we've got these interventions or procedures coded in OPCS 4.3, going from the first one through, certainly in the case of APC, codes are used all the way up to the 23rd place. And again, just some examples of what this might be. Chosen at random, one about the elbow joint, so a computed tomography NEC, and then a primary resurfacing arthroplasty of the joint. So you can see by me tripping up over these words, this isn't necessarily my natural environment, and that's why, you know, often this sort of work, if it's using these things in a specific meaningful way, it's good to have clinical collaborators. So again, here just looking at these very quickly by NCDS cohort member. For this first one, they've just got a single OPCS code. For this second one, they've got two different codes, but we see that in this case, they're not repeated across the other episodes in the spell. So these just relate to the first episode in the spell. And again, in general, that's what we will see, that these are coded at the episode level rather than the spell level. And similarly for these ones. Okay, so just thinking, so those are the key variables that I wanted to look at, just some that occur across several of the HES data sets. Obviously, there's lots of other information in the data sets that's been described already. I just wanted to think a little bit now about how you would define your analysis sample. So the HES data sets will contain, we will be able to identify the cohort members who have a successfully linked HES record. But of course, some cohort members, if they've not had an interaction with an English NHS hospital over the period covered by their HES records, they may legitimately not have a HES record over that period. And sometimes you might be doing an analysis where you specifically want to constrain your analysis sample to those with successfully linked HES records. But I think in more general, you would also want to, if possible, include those cohort members who didn't have a successfully linked HES record, if you thought that lack of a linked record could be meaningfully interpreted as them not having experienced, a certain diagnosis for a certain condition. And so if we believe that any cohort member with a HES record who truly had a HES record would have been successfully matched to it, then we would conclude that any eligible cohort members without a matched HES record, truly didn't have a HES record. But in order to do this, we really need to consider who we think is eligible for linkage. So because these linkages have been done on the basis of explicit consent, then we need to restrict our attention to those who have given their consent for the linkage. That's a certain condition for eligibility for the linkage. But a major feature of these HES data sets is that they relate only to English, also NHS hospitals. So we might want to restrict our attention in terms of eligibility to cohort members living in England over the relevant time period. So that's one thing that we've done in our analyses of linked NCDS HES data. We've considered cohort members to be eligible for the linkage if they reported living in England at any one or more of the waves between wave 6 when they were age 42 and wave 9 when they were age 55. And these dates most closely match the period of HES data availability. So we're trying to place them within England at that, at least for part of that period of time. But I think that this definition of eligibility might differ depending on the context. So we've done a bit of work around this that's included in the reference at the bottom, that if I've got time, I'll mention again briefly in a few slides' time. So a couple of recent analyses to just quickly look at, just to demonstrate the kind of work that we've been doing. So this first one I wasn't involved in directly, but it's more a more applied analysis, thinking about the association between poor mental health in young people and subsequent hospital service use. So this was using the linkage of the HES data into Next Steps cohort data. Within the cohort data, these analysts were deriving measures of self-reported mental health and self-harm, and then also in HES looking at whether they had any, or counting the number of A&E visits using the HES A&E data set, and also identifying diagnoses of mental or behavioural disorder using the APC data set. And then they found that poor self-reported mental health at age 17, so in the cohort data, was associated with a greater probability of A&E appointments in the following decade, and also with a greater probability of a diagnosis of mental or behavioural disorder in hospital. So I think perhaps unsurprising that, particularly for the second of these, we observe an association, but I think that there's there's work to be done around exactly the strength of that association and the implications for the demand and allocation of healthcare resources. So I think this sort of work can really contribute to that. And this is a piece of more methodological work that I've been involved in recently. So over recent years, there's been increasing linkages between cohorts and other longitudinal survey data and administrative data, such as this HES data. And then there's growing interest in whether these linked administrative data can aid analyses of cohort data subject to missingness, which is often the case due to attrition over time or other non-response. So here we were looking at this using HES data linked into NCDS. We derived 58 variables from the HES data, covering areas such as the number of admissions and appointments, the number of missed appointments, or maybe proportion, the different investigations undertaken, and then using the ICD10 and the OPCS, diagnoses and treatments received. And these were done by category, by chapter, as I was discussing previously. So we used a variable selection approach to try and identify which of these HES variables were most predictive of non-response at age 55 so that's a sweep of data collection within the survey itself. We've identified 10 of these variables. So for example, if cohort members were treated for an adult mental illness, then they were 70% more likely to be non-respondents. And so the idea is that if you can include these identified predictors of non-response as what you'd call auxiliary variables in principled methods of missing data handling. So here in multiple imputation, it should help you in dealing with this missingness issue. But here, when we did this, it actually only helped to a limited extent. So essentially no additional gain relative to using variables that we'd identified previously in NCDS using the survey data that were themselves predictive of non-response. So it's somewhat technical methodological work, but hopefully it's another example of a different type of analysis that can be undertaken in this sort of linked data resource. And neither of those analyses are published yet, but I think hopefully they both will be at some point before too long. A number of resources that are available when thinking about the data and what you might do with them. So I think these have been flagged up already. The user guides for each of these linkages. So on the back row here, those for linkages to the HES data, and on the right hand side, I can now from tomorrow, I think, add in the one for the MCS HES linkage, and on the front row, the user guides relating to the Scottish medical records linkages, just for completeness. These are available all from the CLS website, and they're also available from UKDS. When you're searching for these different data sets, there'll be a documents tab or documentation tab, and these will be available there too. A working paper that we published earlier this year was again using the NCDS HES linkage, trying to look in different ways at the quality and the representativeness of this linked data resource. So we started by examining associations between key cohort member socio-demographic characteristics and successful linkage to try and identify potential sources of bias due to selection into the linkage. We looked at the levels of successful linkage within strata of NCDS variables, which may be expected to be associated with hospital attendance as a kind of a sense check. So we were looking, you know, some of them are very directly comparable. So in the survey, people would be self-reporting whether or not they'd had a hospital admission or whether or not they'd had an outpatient visit over a certain period of time. And then we can look and see how that information compares to what we see within the HES data set. And some of it was more around kind of self-reported general health, so less directly comparable, but still giving some contextual information. And we also looked at the population representativeness of the linked sample by using some external data on hospital admission rates in the general population. And the overall conclusions for this, we think that these analyses in combination show that the linkage quality is pretty high and that the linked sample maintains a really good level of population representativeness. So hopefully it gives some confidence in using this linked data resource. And this it's available as a working paper from the CLS website, but some of the results in this will hopefully be published soon as part of another paper too. A few other resources of interest. So there was a closer report a few years ago thinking about how HES data sets can be used, particularly when linked to cohort or other longitudinal population data. In the IJE, there's a nice data resource profile on HES APC, and then obviously on the NHS digital website, there's lots of information too. And that's me done. Thank you very much. So I've not been keeping an eye on the chat. I'm not sure if any of the other speakers have, and there's any questions that we should turn to now.
I've just seen one. Well, there's a question about the slides, which we'll come to. Leah, you asked about the Scottish medical records, and I answered rather bluntly, I'm afraid. I was just excited to tell you the answer. But yes, I didn't go into detail about the Scottish medical records, but actually starts really early. So 1980 for NCDS and BCS 70. So there's loads to look at. And please check out the user guide on the repository if you want to see lots more information. Thank you.
And a question about the slide availability. Yes, I think Richard Steele can correct me if this is wrong, but I think both the slides and the recording will be circulated to all attendees following this within the next few days, I would hope. And someone there with their hand up, Lawrence.
Hello, yes. I have a question about data formats. I'm now an emeritus prof, so I've obviously been around a long while and brought up on SPSS, moved on to Python and other things like that. Recently, I and some of my students have been using a package called NIME, which is incredibly easy for students to start off with, particularly those who are a bit scared of anything quantitative, so it's very useful. The question is, can you get the data in formats that can read? I know that can read, for example, Excel. Do you know what other formats one can get the ATS or the linked data sets in?
So I think that the format of the data is one issue, but I think in particular here, because you would be restricted to using these data within a secure environment, so either the UK Data Service Secure Lab, or if applying to use it via the UK Longitudinal Linkage collaboration within their trusted research environment, I think the issue is more likely to be the availability of software within those environments. And so I'm afraid I don't know if that specific software would be available there. It's not something that I've come across in that context. But I know that, you know, if you're wanting to use Stata, R, Python are definitely all okay. I'm not sure about SPSS in there. I'm not sure if anyone else knows. Yes, SPSS.
It comes in that's how they have it in SPSS. So
certainly with those, that would be fine once you're in that environment to use that software.
Thank you. That's a complete answer as far as I'm concerned.
Great, thank you.
Thank you.
Are there any further questions or comments that you'd like us to address? Okay, well, I'm happy to stick around for a few minutes. So if anyone thinks of anything over the next couple of minutes, just post it. If you wouldn't mind just completing the really quick feedback form that Richard's posted a link to in the chat, that would be amazing. It's really helpful for us to have feedback on this session, and also information on sessions that you would like to see going forwards. And I think, yeah, certainly if any questions come to mind and you think it's too late to ask them after the end of the webinar, then just drop me or one of us an email. I'm sure we'll be happy to discuss that with you as well. I think the key thing is that, you know, we've got this really amazing data resource, and there's so much that you're able to do with it. I think we're very keen for other people to share in this, to use it. The application procedure might seem a little onerous. You're not going to gain access the very next day, but hopefully it's worth doing because of some of the amazing opportunities there. So do get in touch, and we're happy to discuss that. Lawrence, was that your hand going back up again?
Another question that this is, I think, relevant. We've been doing some work trying to link data both from the biomedical side and the social side, so it's sort of biomedical and sociological at the same time, from the Understanding Society survey. That wasn't in the list of things you mentioned. I assume that does not link to hospital episode statistics, or does it?
I'm not sure. That's not one of the cohorts that we're running at CLS, so I don't know all of the details. I know that Understanding Society is available within the UK Longitudinal Linkage collaboration, and therefore will be linked into those different health data resources, particularly that are relevant in the COVID context. And you know, I haven't been doing it directly, but I'm involved in projects with colleagues who are doing exactly that, using data across many studies, including Understanding Society, using the linked NHS digital data sets within UK LLC.
Okay, thank you very much.
I just wondering.
Sorry.
Can I ask something? I just wondering whether there's kind of specific lab-based training for using health data. I mean, I attended a long time ago in York University, but I think the professor moved to somewhere, and then I'm not sure whether the kind of training courses like a hands-on computer training, including data code, etc., it would be available at UCL or in other institutions.
Yeah, I'm not sure if other people have anything to add on this, but I think that there's one or two courses out there about HES data and how to use them in practice. I'm not sure how many run by UCL. You're having a look. I think there's.
I'm having a look. I think
NCRM, National Centre for Research Methods, I think they have some HES specific training coming up in the new year. I'm not quite sure who's teaching on it, but I think that would be helpful looking stuff. It might be Pierre Hardelid, who's based at UCL.
Well, I think there's the FAR Institute here at UCL, and they definitely do the research in that area. I'm sure they run short courses if you want to check that out. Sorry if yeah. But I don't think we do anything in-house here, do we yet? Maybe we will.
I see. Thank you very much.
And I think, was there one more question up here? Sorry if I missed it, but how quickly can data be released? So I'll leave that for someone else if that's okay.
Sorry, you're going to go. You go.
No, you go. Sorry.
No, I don't really understand the question. Maybe it's not coming up on mine.
It's a bit further out. I assume it's yes. Once the application
process takes.
I would cover the application process, and once it's okayed, how quickly would data be available after that?
It depends how long it takes you to write the application. With regards to how long it takes to get it's kind of out of our hands. it's a bit of a how long is a piece of string. I know that the data goes to the DAC, and then the application is reviewed, and then sometimes there are tweaks, and then then that needs to be resubmitted. But if there are tweaks, but it could be, I don't know. You've applied, haven't you, Richard? Do you know?
Yeah, so yeah, obviously it does depend on a few different factors. The Data Access Committee only meets, is it once a month or periodically? So it depends where you hit the cycle. But also because you do need to have some sort of contract, data access agreement signed by someone within your institution with the authority to do so. So that's usually kind of research contracts. It can depend quite how efficient your research contracts office is, which I think can differ between institutions, so that can hold things up a bit. But my understanding is that once all of the agreements are in place, it can be fairly straightforward and quick to make the data available. The actual process of doing that is very straightforward from the UKDS end. Other things could be, as part of the broader process, because you're required to have certain status within ONS, the accredited researchers status, and also to have done, if you're accessing via UKDS, have done their training specific to their secure environment. So you need to make sure that you get booked onto that, and they don't always run as frequently as you might need them to. So there's the potential for hold up all over. But yeah, if you try and get all your ducks in a row as quickly as possible, then once everything's signed off, you should be able to access the data. And then a question, so hopefully that answers that okay. Another one about whether there's any longer term plans to link to primary healthcare data. So I think that is very much something that a lot of cohort studies would like to do, because there's obviously a lot of very interesting information that will be contained within the primary healthcare data. I think it's a bit more complicated than the secondary care data that we have in HES, because HES covers the entirety of, well, perhaps only England, but at least it does cover all of England, whereas if you're looking to use a data set that's based on primary healthcare, then if you're doing that using CPRD, say, or there's two flavors of CPRD these days that cover different subpopulations of the population, and there's other, and it depends basically on the software that's being used by the GPs, whether or not you would whether or not a certain system would have access to their data, and it's a little bit fragmented, which makes it a bit more difficult to do. So either you can try and link all of these things up and try and as best as possible do it for the whole population, or you're relying on one of these single providers of primary care data that might mean that you can only include a subset of your cohort within the linked data set, which then potentially has problems for implications, at least for what you can do in terms of the numbers and therefore the statistical power that you have. So it's a little bit more complicated, but it's definitely something that I know a lot of cohort studies are looking at doing and hoping to do. I'm not sure if anyone else has any more thoughts on that, or kind of CLS specific information on what the plans are.
I know there's some GP data in the UK LLC, specifically the COVID-19 data that was released, but I don't know, I don't have the specifics, but it's worth contacting LLC.
Yeah, I think that's a good point, that yeah, UK LLC is potentially going to have additional data sets linked into it. So there is already some information from GP that's, I think, quite COVID specific, but I think in the future it's worth keeping an eye on that might be where there's more more movement in this area. Thank you. And sorry, another one here. For MCS beginning from an older age, can we get access to data regarding birth situation or gestational weeks by linking with HES?
When you say older, the older age,
I think maybe beginning later in calendar time, and therefore their births will be covered by the period covered by HES data.
yeah, so if it's in the period of the data collection, yes, yeah, there are birth records in the admitted patient care. So and they're way too young to have had a baby, so it must be their birth record. It's a bit confusing because it kind of looks like the same as if it was a parent. The records, if you had a birth episode where you were giving birth, you would still have the same things checked. It's a little bit, or some of the same things checked. So yeah, there are definitely birth records in here.
Thank you. Although I think apologies, I did misrepresent the question a bit there. I think that you're right to point out, because they're only sampled from age 9 months. Could there be a potential complication of the fact that they're not sampled until that far after their birth? Might mean that those records still aren't available. But I think it's yeah, I think once the consent's given, the linkage will be for the entirety of the HES records relevant to that individual, so we'll go back that far.
Yeah, because the consent is from age 17 and the records go back to, well, when they're born or the beginning of the data set. So lots there to look at.
Although a comment that the birth data might be based on the mothers, not the cohort members. I'm not sure to what extent that's the case, I'm afraid.
I don't know. I'm not going to pretend I know.
I've not had a chance to look at that aspect of the data.
I think you'd have
yet,
to
I'm
look at
afraid.
it, yeah. Because it's the diagnostic variables will make it quite clear, you know, what's going on in the data, I think. But there's things like birth status, this is the APGAR score here, and birth weight, things like that. They're there.
Great. Okay, so we've come to the end of the time there, and I think the questions are drying up. So maybe let's draw it to a close.